First, the importance of addressing intergenerational trauma in the perinatal period. So it's always important for us to frame this discussion by remembering that prior to colonisation, Aboriginal and Torres Strait Islander people had adapted and thrived in Australia for at least 60,000 years. And from the available evidence that we have in around 1788, it suggests that Aboriginal and Torres Strait Islander people and children were healthier than most Europeans at that time, certainly much healthier than the Europeans that arrived here by boat. We didn't send our kids down to work in mines or off to boarding schools or anything like that. The state of well-being that was achieved and that was evident at the time of colonisation was centred around connectedness. And this connectedness and well-being also did not happen by accident. We had over 500 Aboriginal and Torres Strait Islander communities, each with sophisticated laws and systems and ways of being, as well as thriving art and spiritual culture. The safety and relational development of Aboriginal and Torres Strait Islander children had been fostered within systems of community care and kinship for millennia. There were practices in place and cultural practices to foster that connectedness. We celebrated those connections of babies from before birth that continued through until after death. New parents were supported using principles of grandmother's law and cared for during birth in sacred places by women who were trained during their lifetime using a sophisticated system of mentoring to ensure there was always clear guidance and support around families and parents when they were getting into trouble. And this included around social emotional care as well as physical care. We had specific practices to foster those dimensions of physical, social, cultural and spiritual well-being, depicted here in this well-known model by Dr. Graham G and colleagues, as I said, starting before birth and continuing right throughout the lives of our ancestors, acknowledging our ancestors even after death. This included having ceremonies during pregnancy for mothers and fathers celebrating important relational milestones, such as when a child is recognising their own kin or country. And complex trauma impacts every aspect of social and emotional well-being because at its core, it's disrupting our connectedness, which we know is essential to our well-being. Hence, sometimes people call it relational or developmental trauma. The other thing that's happened with colonisation, which is why what we're really trying to address within academia in particular at the moment, is that we know that these knowledge systems that underpinned all of the health and well-being of Aboriginal and Torres Strait Islander people was completely disregarded by academic institutions until, well, still is being in a lot of ways, and certainly by governments, the systems and cultural practices and knowledges were suppressed and dismantled through the processes of colonisation. So all of these understandings that were here and are here have not been integrated into the university systems. They're not reflected in the current knowledge base or evidence base that we call. And the research that's been done has been largely led by non-Indigenous people conducting research on Aboriginal and Torres Strait Islander people, underpinned by methods of methodologies that assumptions of knowledge superiority and racism and privilege. And what this has meant is that there's been distorted understandings and evidence published about Aboriginal and Torres Strait Islander people that don't reflect these understandings, and they reflect non-Indigenous values, beliefs and prejudices, so much so that most Aboriginal and Torres Strait Islander people don't recognise themselves in published research. Where are our capacities, strengths and resilience? And then the problem with this in the knowledge, having this evidence base in the knowledge base that's distorted, is that then this is reflected in the societal policies that we have and our healthcare systems and our programs, and then integrated into our education systems for healthcare providers, which then compounds and reinforces the legitimacy of those understandings. It's little wonder that we've seen the health of Aboriginal and Torres Strait Islander people going from the best to the worst in 200 short years during colonisation. We also know, and I'm sure you're familiar with all of this, that these successive waves of violence have been associated with colonisation, starting with the direct conflict and overt violence, then the covert violence and the structural attacks, which has been directly on Aboriginal and Torres Strait Islander families. The front line of the colonial wars in Australia has been on families, including with the stolen generations and the removal of over 100,000 Aboriginal children from families. A lot of this has happened in hospitals shortly after birth, and it's a legacy that we're now trying to grapple with in the health services. This image is from a recent 2020 BMJ article highlighting the effects of war on children in Europe, starting in utero, and then the range of impacts on child health and well-being that cause toxic stress, and then if repeated and not mitigated, can lead to complex trauma and the physical, social and emotional challenges throughout adulthood, which can have the intergenerational effects due to the impact on the relational development and the capacity to nurture children. And I know that you all understand that. There's been some recent evidence coming out that the compounding effect is showing that the impact of this trauma is greater in the second and third generations, even more so than the first generations impacted by trauma. So this is a World Health Organization model produced by Sir Michael Marmot in 2012, showing the impact on health inequalities. And I'll just use this here, superimposing the impact of complex trauma. So we know that historical violence has led to increased rates of direct exposure to violence and childhood adversity, and a range of sociological influences throughout life then either compound or ameliorate those effects. But it's not a fait accompli what happens after early adversity, as you all know. But we know that in the society in Australia that the influences are more likely to negatively compound than positively ameliorate those initial impacts of early adversity for Aboriginal and Torres Strait Islander children in particular. The other thing that's really clear from the Adverse Childhood Experiences study and all of the studies and modelling that have been done since then, that these early adversities are associated with increased health risks, including, it's accounting for approximately 25% of smoking, a lot of obesity, violence perpetuation, and a whole lot of other health risks, are associated with early adversity and trauma. In addition to that, we're also seeing now that the preventive effects or the preventive interventions and public health strategies that we're using are not working as well for people experiencing complex trauma. And that's potentially because of those issues with emotional regulation, low self-esteem, low sense of self-efficacy, and those kind of things. We'll talk to you about the intergenerational effects that you're all probably really well aware of. And then what we see then is this compounding effect on health inequity. So it's not a flat line that it just continues from one generation to the next. It's actually compounding over time. So it feels like we're pushing uphill to address these issues, like we're seeing with the challenges in closing the gap, because we actually are. The other thing that's happening is that we're seeing increase in inequities, not just between Indigenous and non-Indigenous people, but between different communities. So some communities are managing to break out of these cycles, and other communities are really getting, really struggling with addressing these more. We see this compounding effect clearly illustrated in the increasing rates of removal of Aboriginal and Torres Strait Islander children in the child protection system. This graph is showing a paper that we recently published here. It's increased from 9 times in 2016, that of non-Indigenous people, up to 11 times. So this is not, again, a flat line. This is actually getting worse, and it's an absolute national crisis, and we need to be addressing it. So the perinatal period, this time during pregnancy and birth, is really critical for parents who have experienced child maltreatment or experiencing complex trauma for 3 main reasons. First, we know that there's this convergence of risk factors for experiencing distress as outlined here on this slide. These include things like having vulnerability to pre-existing mental illness, historical trauma that's incurred. We know there's increased risk of family violence at this time. There can be housing instability, financial insecurity, increased isolation. There may be previous birth trauma that can be triggered. There can be experiences of racism and lateral violence. Then you throw in the sleep deprivation, all the hormonal changes that are more, make you more sensitive to being protective behaviours at this time that occur, and the intimate nature of all the things that happen during pregnancy and birth and parenting, including intimate procedures that can be really triggering, particularly for people with experiences of sexual trauma, can really trigger these responses. And this is for most healthy young adults, and this is what parents have to remember, healthy young adults, they probably, for most people, it's the first time they have contact with the healthcare system, and since they've left school, and they may be experiencing these trigger responses that they're not even aware of. It's almost like it's a natural stress test for experiencing trauma-related stress. And because of the effects of freezing, dissociation, and avoidance, many parents may not understand that the cause of these distressing emotions, and this can be really, really confusing and distressing, and it can also result in behaviours that compound the problems that they're having. For example, the flight response and avoidance and may result in them not turning up to antenatal care, and that in itself, in many services, is unfortunately can be a trigger for a referral to Child Protection Services. If they're freezing and dissociating, they may not be able to remember or understand what's happening. And of course, if they get angry in this setting and violent, that can have catastrophic circumstances for everyone involved, particularly the child. But the really important and positive thing that's clearly emerging from the research is that the transition to parenting, despite all of these challenges, is more likely to be positive than negative, offers a unique life course opportunity for recovery, even after severe trauma. And we've seen this in qualitative studies showing that post-traumatic changes during this period were more likely exclusively positive than negative. We've also seen it in the longitudinal studies of youth in detention in America, where they've done these studies showing that parenthood was the only natural turning point, altering really negative trajectories for a lot of women. Unfortunately, we haven't seen that effect for men, but that's probably to do with other things, not that there's not the opportunity there. So we know that it's a real positive strength-based time can disrupt these vicious cycles of trauma into a virtuous and transform them into this virtuous cycle of positively reinforcing elements through nurturing the love that the children bring into the world with them and all those attachment processes that occur, and really heal those pathways in the brain to, love is the healing salve for complex trauma. And that's what's inspired the title for our project, Healing the Past by Nurturing the Future. From a public health perspective, there's few other healing opportunities for relational trauma as strong as this transition in parenting. And finally, as I said, this is the first time since childhood most people have contact with health services. But this does require a structurally competent system using the expertise within the whole system, as highlighted in the Royal Commission here. And we know that most people working with Aboriginal and Torres Strait Islander families know this. In this survey in 2014 by the Centre of Perinatal Excellence, they found 98% of service providers rated trauma, stress and grief as significant or highly significant. However, almost half, 43%, did not feel comfortable or confident that their organisation could support parents effectively. This is a review of the recent Royal Commission that we've had here in Victoria, just highlighting the importance of addressing this during this time. And I'm running a little bit slow on time, so I'm going to click through some of these fairly quickly. But we've had 3 phases for this project. First of all, the 2018, we've done co-design for 4 years. We're just starting a pilot in Morwell, and we've got the plan for scale up. And I'll flick through these slides and you can have a look at some of these papers later that really show you what we've learned. We've published a lot. It's all on our website. So the aim of the project is to bring together the emerging Western evidence around trauma and the millennia-old wisdom from communities to co-design acceptable, safe and feasible strategies for parents experiencing complex trauma. We started with this co-developed conceptual model, looking at these principles on 4 domains. First of all, having awareness of what it is so that people understand it and respond and act appropriately within health services so we're not re-traumatising them. That we have appropriate support strategies for parents available, and that's a broad range of strategies, but we really need mental health expertise within that broad range. Having appropriate assessment tools, which we've been working on, and we've just finalising a draft of that now. And importantly, that we have safe strategies for identifying or recognising complex trauma so that we're not causing more harm. This is our co-design plan, and again, a number of papers here showing qualitative review as well. We grounded it in experiences of complex trauma. We used a process called intervention mapping, which is a very comprehensive process of working through in a logical way, considering the context and the views of people involved. The yellow boxes up the top are all the activities, and the numbers represent all different papers that are published for that. Then down the bottom, we've had we basically reflect on the activities that we've done, and we plan for the next activities within the workshops that are aligned with the intervention mapping steps. This is a summary that we grounded, as I said, this in parents' experiences. This is a very comprehensive systematic review of parents' experiences in complex trauma around the world. 351 parents involved in 21 studies, and really worth having a read of that. Fundamentally, in workshop 2, we asked parents whether we should even be talking about complex trauma with Aboriginal or Torres Strait Islander parents, and if so, why, how, and who should do this. And this is, I think, is a really good paper for all of you to have a read of, thinking about how you have these discussions about complex trauma, the importance of trust, having the capacity to respond, cultural methods of communication, strength-based approaches, and never underestimating the importance of respect, caring, and compassion. I've run out of time, so I'm just going to flick through this, but this is, again, a unique opportunity, this paper describing parents' views of what sort of support they want, centering around connections, support for wellbeing, and support for their transition to parenting. And one thing, what we found is that if one of these things is disrupted, it impacts negatively on the other 2. And if we support one, it also supports the other 2. So that mutual effect. So this is another one of the workshops that we had with all the people involved. A few more papers coming out of that around the co-design, which really resulted in the design of the program that is currently being piloted in Morwell down here in Victoria. So that's that step there. And this is a model, again, that we're looking at. So we're just at the moment in step 4 in the production phase, and then we'll be implementing next year and then evaluating. And to let you know that we've combining this work with a whole lot of other amazing programs, and a huge program of work that was funded recently in the budget called Replanting Birthing Trees. And as I said, bringing together all these different programs with 48 investigators under this conceptual model to replant the trees. So we've got the Western research evidence grounded in Indigenous knowledges and a range of strategies here that you can have a look at on our website. This is a really new, exciting program of work that we're all very excited about.